Okay. So with all those housekeeping notes out of the way, thanks for joining us again today. We're excited to kick off this is our last session in NL Support's quantitative research design series. So we have with us Dr. Stephen Czarnuch. He's an associate professor of biomedical engineering, and he's jointly appointed to the Faculty of Engineering and Applied Science, as well as the Faculty of Medicine at Memorial University. I hope I got that right. So Dr. Czarnuch, I will pass it along to you to get started on your very interesting presentation.
Wonderful. Thank you very much, Julia, and thanks to Holly for inviting me here today. I hope everybody can hear me. I'm not up in my office as normal because I have a couple things going on in my home right now. So I apologize. I only have one screen, which means it's going to be challenging for me to directly see the chat. I have no problem with anybody jumping in if you have any questions, though, or throwing something in the chat. Maybe Julia, if you're able to keep an eye on it, maybe you can help if something is critical or needs to be said right away.
I was going to say, Dr. Czarnuch, I'll monitor the chat. You focus on your presentation.
Yeah, absolutely. Thanks very much. Okay, so as Julia said, I am Stephen Czarnuch. I'm associate professor, joint appointed to both the Faculty of Engineering and the Faculty of Medicine and Engineering. I am a computer engineer. I also have an appointment to the discipline of emergency medicine. And I'd like to say right off the bat, happy Tuesday. One of my kids pointed out to me today that the date is 2/22/22. And it's a Tuesday, so that's kind of an exciting thing for me. Really quick background about me. Hold on, is my screen in? Yeah, a little bit of quick background on me. I'm a biomedical engineer. I worked for 10 years in industry before I went back to do my PhD in biomedical engineering at the University of Toronto. What that really means for me is that I apply a lot of computer engineering or sort of technical research and design principles to healthcare applications. That's sort of how I view it. And this talk is really supposed to hopefully support some of the other talks you've seen, which are ideally presenting some more traditional research designs. The idea behind this is that if you are a technology or an innovation researcher or designer, you may find that some of the gold standard approaches to collecting evidence to support your work and your research and your development may not actually be effective or appropriate. So we'll talk, especially toward the second half of the presentation, on what I mean by that and what alternative study designs exist out there for people who are maybe looking at how an RCT, for example, a randomized controlled trial, is not appropriate for their research. Before that, though, I'll quickly talk a little bit about technology and healthcare and what that means, talking about sort of current and future trends, just to set the stage and introduce the idea of disruptive innovations, which will set the stage for a brief discussion on current states of evidence in healthcare, in particular randomized controlled trials, and what the challenges with implementing some of those study designs are with disruptive innovations. And of course, closing it out with a discussion specifically about research designs that are appropriate for those types of innovations. So this is something that you'll probably see a lot in the news. These types of publications are pretty common, looking at really exciting healthcare technologies that every executive should be excited, or new things in the future. In my experience, most of them are artificial intelligence based. That seems to be a very common trend right now in research and in development. So you see lots of buzzwords around things like artificial intelligence and blockchain, automated voice recognition, voice searching, chatbots, virtual reality, harvesting data, deep learning, through everything like social media and through your email habits and things like that, personalized and intelligent mobile apps, all these kinds of things. Really, to me, it's just a sort of snapshot of how the world is viewing technology. Lots of exciting things out there, but one of the things that I find is really interesting is that as much as if you do a quick search on, advanced healthcare technologies that are emerging or coming out, you'll probably find that not a lot of them are translating into actual practice. So, you see these images here of sort of intelligent user interfaces for surgeons, or, people using virtual reality and augmented reality to do things. But something seems to be happening year after year that are preventing these technologies from actually translating into health and healthcare applications. And I think that this is common across many healthcare fields. Lots of people are coming up with new outcomes and new design targets and new features. It's very, very hard to change the current paradigm of healthcare. Technology is not immune to this, but I think that there are some systemic issues specific to technology developers and technology researchers, and in specific related to study designs that we're going to talk about today. So when we think about technology-based interventions, in this context, I'm really speaking about technologies very, very broadly. Technologies can be the most state-of-the-art artificial intelligence, everything from absolutely, intelligent environments that understand what's happening within them. And again, remember that these are often in a bit of a dream world, or not necessarily in a real applied world, but even conceptually, these high-level, highly intelligent solutions and interventions, but also can go as simple as things like pillboxes and reminders and environmental modifications, being able to accommodate different forms of disability. So lots of frameworks exist. In Canada, we've adopted an ISO standard that's generally accepted worldwide, which is a relatively comprehensive framework looking at assistive and therapeutic interventions. And so here, we're getting a little bit more nuanced in terms of how we frame the idea of a technological intervention, specifically looking at things to help accommodate some sort of disability, whether it be an acute disability or a short-term impact of trauma, or whether it's a more long-term chronic disability. And within this taxonomy, or this sort of classification, interventions, and specifically healthcare interventions, are broken down into three categories: either assistive, therapeutic, or service delivery augmentation. I'm going to very briefly spend some time discussing what these mean, because I think it's interesting to think about the fact that we're taking the issues associated with healthcare and kind of breaking them down into different sort of perspectives on how we view the end users. And one of the things that I'd really like to emphasize as a latent theme underpinning this entire discussion here is that the idea of disability is often much more complicated than traditional study designs, in my opinion anyways, than traditional study designs accommodate for. So the idea of disability can be viewed in terms of sort of a functional or performance-based impact on a person's life. So assistive interventions are specifically designed to support some sort of functional activity or some sort of functional performance deficit. So a prime example would be a traditional wheelchair or memory aids like you see in the middle image, but can be much more sophisticated in terms of the wheelchair on the left here, which is a more intelligent automated wheelchair that has some capacity to be able to independently navigate and interact with the user. So you can see that this is not just something like an intelligent wheelchair is not just tackling issues related to physical disability, but also perhaps cognitive disability, or some more nuanced social interaction components associated with disability. The device on the right is a commercially available memory aid, which is not just using a smart aid, but also in some ways passively interacting with the environment and understanding the appropriateness of timing and the appropriateness of interacting with the user. So for example, if a person is watching a TV show and the medication or something you're trying to prompt them to remember is not critical to be happening at that particular time, then these intelligent devices can understand a little bit more about the context of what's happening around them, and perhaps, for example, delay a reminder. Therapeutic interventions or therapeutic innovations, I often in this lecture or in this discussion I'm going to be interchanging innovations and interventions, because I'm speaking specifically about these modern technological innovations that are healthcare interventions. So from a therapeutic perspective, these technologies can really be focusing on not so much a functional loss, but on restoring or improving a loss of functionality that is perceived to be able to come back. So this is sort of the idea behind therapy. On the left side, you'll see what is a robotic exoskeleton that actually has the ability to offer propulsion for gait support and loss of lower limb control, helps support balance and can support things like falling. So in this case, for example, somebody who has lost entire lower limb functionality but still has neurological control over those limbs in some measurable way can actually use something like these exoskeletons to be able to move around. Virtual reality in the middle image here has been used for all kinds of things, particularly within cognitive domains. So you see the image on the right, overcoming phobias of spiders, or flying, or feeling as though you're being I can't think of what the word is, but trapped within some sort of space, or even traditional therapies associated with PTSD or relationship disorders, alcohol abuse. All kinds of really interesting uses of these technologies for therapeutic interventions. But as I've said sort of earlier on, and I'll continue to reinforce, we don't really see a lot of these entering mainstream healthcare practice. And so again, I think that one of the big issues with this is the way that we evaluate and obtain clinical evidence to support their effectiveness or their efficacy, as we'll talk about shortly. And then also some of these interventions, these technological innovations that we see really becoming mainstream, specifically in the research world, but also in terms of some smaller startups, are interventions that are targeting service delivery. So in this case, we're not even necessarily looking at the patient in terms of a disability, however we want to classify or qualify or quantify disability, or a therapy in terms of restoring some sort of lost functionality, but specifically looking at the process of service delivery. So telerehabilitation is probably the most publicly well-known and sort of successful technological innovation that affects service delivery. In this case, you're using some sort of technology for telecommunication to support either rehabilitation or patient-doctor connections, supporting rural and remote locations. Telerehabilitation has really, in many ways, almost crossed the boundary, but I think that I would argue in many cases, we haven't seen that also translating into more modern forms of healthcare delivery. Although interestingly, as I'll probably mention a couple times throughout this webinar, the introduction of the global pandemic has really seen an interesting pressure put on the use of technology. And I think this is a prime example. We're using a virtual meeting room to be able to share information. Anybody who's tried to reach out to a family doctor, if you're fortunate enough to have a family doctor, you've possibly met your family doctor by phone, or if you've had some sort of physical condition like a skin condition, you've maybe had the opportunity to snap some photos and upload them so that your family doctor or a specialist can see them. So, you know, we are seeing some penetration of these technologies into mainstream health and healthcare, but other things are mobile applications or ambient home monitoring systems. This image on the right is intentionally cluttered, and it's showing the idea of how advanced some of these technologies can be. In this case, we can see what would be some sort of smart environment that is instrumented with all kinds of different forms of technology and user interaction capabilities. So whether microphones or water sensors, presence sensors in showers and surveillance cameras, but home control systems that are not only interacting actively and passively with the inhabitants of the room who might have the disability, or whether cognitive or physical or social or otherwise, but also the caregivers and the users, and broader implications to connecting with healthcare service providers as well. So obviously I could spend quite a bit of time talking about lots and lots of modern interventions that are under different forms of research and development. But the idea of translating some of these really, really cool, in my opinion anyways, really, really cool interventions and innovations to more mainstream healthcare are really challenging. These interventions can be extremely complex, both in terms of sort of a more pragmatic perspective on how, if you think about this intelligent environment, somebody has to install and maintain that environment, and also complex in terms of the technology itself. Technology tends to have a bit of a stigma. You have to come from a sort of science, technology, engineering, or math background to be able to consider yourself a tech person. I do a lot of work with healthcare providers who are adamantly clear, even though they might be more technologically advanced than even me or some of my graduate students, that they're not tech people. So there are interesting boundaries between the translation of technology to market. But more specifically, a lot of these interventions are very nuanced and customized to the users that they're intended for. So by nature of targeting diverse users, that brings into question the relevance or the applicability of some of our methods, like I'll talk about in the next couple slides, like randomized controlled trials, where we're looking for relatively strong control over the populations we're doing research on. We want very homogeneous populations, and in a very pure sense, a lot of the experimental study designs that I'm presuming have been covered in different venues, although like I said, I will briefly go over them. These diverse experimental study designs that we can rely on, whether they be experimental or observational in nature, are ultimately trying to reduce the population that we're doing research on into a very homogeneous, uniform group that we can look at and literally attempt to only modify one single variable, which would be the intervention, so that we can do a strong statistical approach to measuring change. But users in healthcare applications are not homogeneous. They're very heterogeneous and diverse, and as are the environments that they're living in and operating in. So these innovations really are struggling to strive and struggling to survive and thrive in these environments where rigorous control is being imposed on the generation of research evidence. Also, from a societal perspective, whether it be from the users of these technologies or the clinicians who are using them or the caregivers or other stakeholders who are supporting them, there's often resistance to new technologies of various forms. And we're going to stay a little bit away from that. I think we could do multiple lectures on why technologies are resisted in terms of acceptance and adoption. But mostly what I would really like to focus on is how we can translate these technologies from these early developmental stages into later stage sort of clinical applications through the acquisition of rigorous evidence. And I think that the concept of rigorous evidence is what I'm really calling into question here, what rigorous evidence means, and particularly in relation to study designs and clinical applications. Because the truth is, if we're going to see something translate into clinical application, we have to be very sure that we do have appropriate and rigorous clinical evidence, because, you know, at the end of the day, lives may be on the line. So these technologies, these innovations, a term emerged quite a while ago, probably in the early 2000s, circa 2005, 2010, this idea of a disruptive innovation. And the idea of disruption is really this idea that we have current paradigms that are in operation, and they tend to be well established. So we see that, for example, in gender studies, and we see that in race and ethnicity studies as well. It's very, very hard to disrupt the dominant paradigm. And the same is true for healthcare applications, and the same is also true for technologies in general. So disruption is really a process, in this context anyways. A disruption is a process where you can consider how a smaller company, whether it be, you know, an actual business or whether it be a researcher like myself, who will in almost all cases have fewer resources, whether that be, you know, just access to funding or, you know, human hours to do development. How can a company who is smaller and has fewer resources actually disrupt or change this established or incumbent business or process? And so this image on the right is a little bit cluttered in the way that it's displaying the information, but the idea is that the incumbent businesses or the incumbent paradigms are generally focused on improving products and services for their most demanding customers. So whether that be in a healthcare application where you are looking at the clinical makeup of people coming into emerge and saying, you know, we recognize that renal issues are, you know, a huge proportion of our population, so we're targeting all of our resources and services toward the dominant issues that we face. And this is common both from a business perspective, where we're trying to generally accommodate the largest customer base or the most profitable customer base. The same is true for technology developers who, you know, even if it's a new innovative technology, it eventually ends up becoming a technology that satisfies the larger population. And when we think about injury, and when we think about disability, and we think about healthcare, it doesn't mean that a large portion of people don't have non-dominant issues. It just means that there are often groups of people, particularly in local ecosystems, that are struggling with common issues. And so, entrants prove to be disruptive to these technological and healthcare incumbent forces by successfully targeting these overlooked segments. How do we target these smaller populations that are understudied and are underserviced? And even in situations like Newfoundland, that could be as simple a concept as targeting rural populations. Our rural population is proportionally very large, but our rural population is also very, very diverse, and one solution doesn't apply to all of them. So in many cases, we have large healthcare centers that cater to our urban populations. But what happens to these technological innovations that are targeting these rural populations? So the traction comes from being disruption. The traction for these companies comes from being able to target those smaller, more nuanced issues and populations. And I argue that one of the things that is preventing translation of these technologies to broader market is what we consider acceptable clinical evidence. So we know that many of these startup companies, we see lots of them emerging in St. John's over the recent years. They really want to build an evidence base for their products, and that's become clear. I am currently working with, I think, 4 startup companies through various direct means in an attempt to be able to develop both clinical and technological evidence that will support products that they're developing, so that they can now seek, for example, additional funding or start to gain traction in the healthcare community. So these innovations within healthcare all innovations within healthcare are necessarily held to a very high standard. But these clinical practices that are common for generating these high standards are largely emerging from pharmaceutical development. So pharmaceutical companies and the randomized controlled trials specifically are considered the gold standard of evidence. And these trials, though, specifically were meant to try to isolate the impact of one of these pharmaceutical interventions or modern developments, and see if in isolation over large groups of homogeneous people we can measure some sort of impact using very rigorous and well-developed statistical methods. Unfortunately, as we'll see on the next slide, a lot of these approaches are relatively unsuitable for technology-based interventions. I argue in many ways that they're counterproductive to the goals of supporting people with disabilities or healthcare issues, and counterproductive to creating benefits for society. And I think that the prime example, again, within Newfoundland is servicing rural populations, where undoubtedly we have to service these populations, but we are just constantly putting these solutions on the back burner. So what is evidence, and what is this idea, evidence of what? Is it of efficacy or is it of effectiveness? Because efficacy is really looking at the performance of a single variable under a very controlled situation, and effectiveness, strictly speaking in a healthcare context, is looking at how well an intervention behaves under very real world pragmatic conditions. So that, the goal of something like a randomized controlled trial is very, very different than the goal of a much more pragmatic study design that's looking for how well something works in a real world scenario. So I'm going to briefly skip over this because I'm assuming everybody here is quite familiar with it, but just showing that the evidence pyramid, is really focusing on this blue stripe in the middle, which is, the dark green stripe, which is randomized controlled trial, or the light blue stripe, which is sometimes missing from the evidence pyramid, which is sort of this idea of taking randomized controlled trials and synthesizing these data into best practice guidelines, which tend to be a little bit softer. But even above that, we see things like systematic reviews and meta-analyses, which are generally trying to go out into the world, find randomized controlled trials on specific topics and synthesize those data into larger sort of accumulations of randomized controlled trials. Everything from the light green down is sort of lower quality evidence within the evidence pyramid. So non-randomized controlled trials randomization we'll see is really important. Cohort studies, all the observational studies tend to be considered a lot less reliable in terms of quality of evidence. And then down at the very bottom, we have expert opinion, or as I like to call it, eminence-based medicine, where we have people who are relying on a long history of experience and information to make decisions, and often not even turning to what we would consider best practices toward the top of the pyramid. I'm going to take a quick pause just to take a look at the chat, which looks like it's empty, but just in case anybody wanted to chime in and ask any questions or throw in any comments before I continue.
Hi,
Hello.
Steve.
Yep, I can hear you.
Yeah, you can hear me?
Yep, I can hear you very well. Thank you.
Yeah, I really enjoyed your presentation so far. It's making a lot of sense to me. And maybe I'll wait till you're finished until I bring up some comments about the technology and how it's being used in some places. Describing how you are describing the use of technology in a control trial. I've got something that I'd like to share with you and the group about something that we're doing, just started, that will, I think you would appreciate what we were doing about exercise in rehabilitation with a certain group of patients. So it is a group, and there's already been done certain trials previously.
Okay.
And they're looking at advancing this, but it's just a little tiny start in what you're talking about here right now.
Absolutely. Yeah, I would be really keen, Austin, to be able to hear what you say, and maybe, hopefully you continue. Thank you for the positive feedback so far. Hopefully you continue to find it useful, because, when you think about rehabilitation settings in specific, that's a really, really challenging world where, solutions have to be very specific to an individual. So yeah, absolutely. I'm planning on leaving maybe 15 or 20 minutes at the end for some open discussion. I think that would be wonderful. And if you feel like at any point in time you want to jump in, absolutely, please feel free to jump in.
No problem. Thank you.
Yeah, thank you too. So randomized controlled trial, I think most people are relatively familiar with it. This is the gold standard approach for collecting and evaluating data. And, you know, as Austin will probably know, if you complete an RCT successfully and it's reviewed appropriately, it's generally viewed to be really good evidence. Some of the neat and effective things about randomized controlled trials, or RCTs as I'll refer to them, are randomization. So that's an attempt to reduce all kinds of things like bias and you know, issues with, you know, the humans that are involved in both the intervention and the people receiving the intervention, blinding as well, same idea, so that people are not changing their actions based on what they're seeing happening. Control and intervention groups. So here you have ideally two groups that are 100% identical, with the exception of one group receiving the intervention and the other not receiving the intervention. This is a beautiful dream, but in a rehabilitation setting, it's very, very hard to have two people in a room together, one getting an intervention and one not, and the one who's not getting the intervention not knowing about it, or, you know, not receiving any intervention. So we'll see that these are common themes that emerge in technological solutions. The nice thing about RCTs, though, is because of the way that they're structured and developed over the years, there's a rigorous statistical approaches that are relevant to them. And even the concept of reporting results and how you report RCT results has been relatively strongly researched, all kinds of guidelines. I've included one here for anybody who's interested. And the entire structure of an RCT is such that if you follow the rules and you conduct it properly, your evidence is and the contribution of what your research is and your findings are relatively well understood. And that's the main take-home message of an RCT. So within this idea of completing RCTs, there's a sort of larger picture of clinical trials. How do you conduct clinical trials? This is a well-published guideline. So the first step is small group testing. You include a small number of participants. Again, though, these participants are considered to be relatively homogeneous in terms of all of their characteristics, except for the intervention they're going to or not going to receive. Initial testing is really about safety and looking at, you know, adverse effects. Is anything going to hurt or cause harm to people as we ramp up our studies? So, you know, arguably the groups that are involved in these early stage trials tend to be, I use the term loosely, but the worst of the worst, people who are desperate for help and looking for help. So, you know, arguably there is a bit of bias already in this process. Then, you know, we move to larger group testing, where we're starting to transition as we move across this arrow. We're really starting to move into more and more about evaluating the intervention itself and what the impact of the intervention is. And toward the end, we're now looking at how we can, within post-market evaluation, how we can roll this out broadly and, you know, arguably from a pharmaceutical perspective, profitably across the continuum. So the challenge with technology, though, is that these solutions that we develop, and, you know, we think about exoskeletons and the cost of an exoskeleton, we are never going to be able to produce hundreds of thousands of these devices to you know, complete a phase 3 clinical trial. It's just not feasible in many cases to even have more than a few of these, which are targeting very specific use cases, or are maybe not necessarily, you know, designed to go home with a person. And you know, when you think about pharmaceuticals, whether you're taking 5 pills a day or, you know, 1 pill a day, it doesn't really matter. It's not taking up a lot of space or time in a person's life, whereas technological innovations are necessarily a lot more involved and nuanced. So the weaknesses of RCTs, I'm not going to spend a lot of time on this because these are relatively well known and well published, but basically time and cost are the two things that you hear a lot. When you're rolling out a randomized controlled trial with 100,000 people across 20 different sites, there's just a lot of coordination and effort that goes into that. But, you know, getting a little bit more, you know, relatable to this lecture is this idea of ethics. So if you think about a pharmacological or, you know, pharmaceutical intervention, the whole premise of a pharmaceutical trial is that we don't know whether it's going to do what we think it is. In the case of a technological intervention, especially from a startup company or from somebody who is building something, they've done the work and they believe that this intervention is going to be good. So if you have an intervention that is going to be helpful, whether it be something even as primitive as a new cane that just reduces wrist and elbow strain, why would you withhold that from somebody? You know, why can we not envision study designs where everybody gets it, and then we work together as a group to refine and improve these things? And this is very common in rehab. and very common in psychological interventions where, you know, we're developing things that we're quite sure are helpful. You know, why would we withhold that from somebody? And then this idea of conflict of interest. So because RCTs, and I don't want to get into this one too much, but because RCTs are driven by, you know, pharmaceutical type research, RCTs are almost always funded by pharmaceutical companies. And so, you know, lots of reviews out there. I had one in my notes, but I can't see it because I don't have two screens, but over 500 RCTs were included in a meta-analysis that was combining them together. And I think 300 of them had clear conflicts of interest because they were funded by the pharmaceutical companies who were making the intervention, but they were not disclosed. So, you know, 60% of the you know, supposedly blinded RCTs were not necessarily free of conflict of interest. And what we mean by conflict of interest is that the researchers, scientists, and stakeholders who are conducting the randomized controlled trial have some potential benefit to gain out of a successful trial. So my little image here on the bottom right shows, you know, a boat, and ideally in society's perspective, we want that boat to be going in the direction that is of benefit to society, but sometimes individuals are paddling in the opposite direction or in another direction. So specifically thinking about innovations, if we think about technology, you know, some interventions, like I said, have obvious observable benefits. I already talked about that one from an ethical perspective. But really the problem with RCTs is that they're known for having findings that are difficult to generalize to real world context. They're looking at large homogeneous groups. And then, you know, how do you apply that to an individual who's living, you know, in Northern Labrador when most of the participants were in, you know, a downtown urban London center? Over-reliance on group means overlooking valuable individual responses. There's an increasing push on understanding what individuals want and need rather than sort of pushing healthcare onto individuals, talking about individuals specifically and what their needs are. And truthfully, like I said, within these rehabilitation settings specifically or other healthcare settings, populations aren't homogeneous. It's almost impossible, whether you say that, you know, a 43-year-old man, 5'11", 180 pounds, and you have another, you know, 43-year-old man, 5'11", 180 pounds. We're not the same person. Those are just three factors that happen to be the same. And so the solutions are suffering in many ways because of that. RCTs only are measuring the impact over the period of the trial. In many healthcare applications, these are lifelong issues. The effects of the intervention and the issues associated with whatever the disability are, or the, you know, the medical issue are often lifelong. And RCTs don't accommodate for that. Cost and funding challenges. What if you have a great idea, but you just don't have money to do an RCT, or the time or the resources to do it? And then I think number 7 is one of the things that is nearest and dearest to me. If you're working in sort of the bleeding edge technological innovations, the technology is changing way faster than an RCT. A typical RCT is approximately 5 years from start to publication of results. We've seen this specifically through COVID, where we've, as a society, somewhat accepted that we're going to bypass some of these processes so we get rapid results. But, you know, even fast within a COVID context is 2 years, 3 years for an RCT. Within 2 or 3 years, my entire technology platform has become obsolete. So, you know, in many ways, I don't have time. The target is moving too fast. But it doesn't mean the innovation isn't good. So what can we do? Well, you know, this whole idea of changing how we view things and acknowledging some of these things. And we'll see as we turn to the literature that some of these solutions have already been here. And it's not, you know, these are not necessarily new solutions. This is just new ways of looking at specific solutions. I'm going to go a little bit faster because we're already over 30 minutes in. So one of the things here is, you know, consider developing these or adopting these different development models that are used predominantly around the world, both in business and in technology developments that are non-healthcare related. But, you know, think of ways that we can apply these to healthcare innovations. So specifically for the rest of this presentation, we're going to be existing within one of these phases. We'll start with phase 1, which is really about how you go from idea to a prototype. Phase 2 is the idea of taking a prototype that you have some confidence in and moving forward on it, you know, as quickly as you can. And phase 3 is kind of the idea of a bit more permanence in your type of solution, but it's intentionally a circle. It's not that linear model. This is constantly iterating over and over again. And one of the things that I realized I didn't include on this is that users are necessarily, whether they be the patients or the clinicians or the other stakeholders who are involved, everybody is involved in this process all the time. So this is no longer a linear process of, phase 1, 2, 3, 4, and out the door. It's just a constant iterative process of collecting data, refining, revising, with everybody who is involved in it, understanding that this is a shared approach to taking an intervention that is not mature in clinical evidence, which doesn't exist, and kind of slowly bumping all of them up at the same time. So starting in phase 1, again, I'm going to skip a lot of this technical stuff, but phase 1 is really about idea to prototype. And then if you think about completing phase 3 and feeding back into phase 1 again, we're always taking a new idea to a new prototype. You're never at the end. You never cross the finish line. There is always a new prototype that's coming out as new technologies come out, as new information and new evidence come out, as you get feedback from individuals and situations. So primary outputs here, we're really looking at just starting to document things and get things pen to paper. But more than that, really engaging users. So how do we figure out who the users are, who the relevant stakeholders are, and understanding the whole delivery process as early as we can. So study designs, I've set the stage for RCTs being inappropriate. Really at this stage, this is a whole different way of looking at it. And in many ways, if you think back to the evidence pyramid, one of the things that I forgot to mention is you will see that qualitative research doesn't even exist. Qualitative meaning sort of the non-numerical collection of evidence and information. Often it's perceived as interviews and focus groups and speaking to people, individual, and hearing their lived experiences and what their perspectives are. So here there's this sort of technology experiments and technology evaluation doesn't exist on the evidence pyramid as well. But the idea here is, how do you take your innovation, your technological innovation, and evaluate it against technical or performance requirements? And the biggest question here is, what are technical and performance requirements? So one of the limitations I think technology developers face is that technical requirements tend to be very, very literal in definition, whether it be, uptime or downtime or crashes or, things like that. But technical and performance requirements can also include user experiences. And so, these technical evaluations become very, very important early on in terms of understanding a user's path through the experience, and where within that path through an experience with an innovation or an intervention, where within that path things went right and where things went wrong, so that we can refine our solution. So to do this, study designs that are appropriate for these early phases are, of course, qualitative research. I am a strong proponent of qualitative research as being one of the highest forms of clinical evidence. So we're collecting and analyzing non-numerical data, really looking at individuals and understanding their reality, their social reality, their physical reality, their perspectives on health and healthcare. And this is why I believe things like RCTs are very, very limited in their perceived evidence and their value of their evidence, because there's no discussion within an RCT of how the humans using the intervention actually feel outside of the primary clinical outcomes. Also, though, lots of room for quantitative research here, but most of the quantitative research in these early phase, and quantitative meaning numerical, the traditional experimental and observational studies that we've become relatively familiar with. Descriptive studies, again, this idea of user experiences, and correlational studies. So not necessarily looking for a cause and effect type of understanding, but really a fact-finding mission, a needs assessment. I've heard Holly a couple of times, quite often when I talk to Holly, she's saying needs assessments. And this is really understanding what user needs are and what factors are impacting these technologies that we're developing. And then mixed methods approaches are really just combinations of everything, more than one method, rather than committing to an RCT as the premium form of collecting evidence. Thinking more broadly about using multiple forms of data collection. Typically, though, the term mixed methods is referring to combined qualitative research with some other some other quantitative approach that is lower on the evidence pyramid. So whether it be cohort studies or case studies or surveys or things like that. One of the things that probably a lot of people who would watch this aren't familiar with are a study design called a single subject research design. So the idea behind an SSRD, or a single subject design, is that people can also serve as their own controls. So we think about a randomized controlled trial where we have one group of people who are all homogeneous in terms of whatever factors we're stratifying them by. We divide into a control group which doesn't receive the intervention and a group that does receive the intervention. There are study designs, SSRDs, where a person serves as their own control. So you look at a person and study them and collect actual empirical, qualitative and quantitative data before an intervention. Apply your intervention, study that person and collect data during the intervention, and then remove the intervention and see if they go back to some sort of baseline performance, and then maybe apply it a second time. So a couple of strong things about the study design are that we're using repeated measurement over a period of time. Within the baseline group, you may say, for example, that we're going to follow a person for 1 week. Then we're going to use our intervention, follow them for another week, remove the intervention for a week, and we're going to sample them 3 times a day so that we have this idea of repeated measurement. And the strength of this is that we're overcoming some of the statistical limitations of individual single measures. So the nice thing here is that we can look at how different individual people respond, and we can conduct these single subject designs across multiple people and synthesize those data rather than treating every group as one homogeneous group. We're treating people as individuals and seeing if we can figure out through the combination of these mixed methods what the impact is being caused by. So here we have just more for reference if anybody wants to look back on this. Different designs within series design is basically looking at just one person over time between series designs, a series being a baseline and an intervention. It doesn't even have to be one intervention here. Baseline A, the A phase is just a normal a normal day in a person's life. B1 is peer tutoring, and B2 is a second form of peer tutoring. So it's a within series if it's the same intervention. It's a between series if they're 2 separate interventions. Combined series can be a mix and match of these. But the neat thing is these are all the same people. So days across the bottom. If you look at baseline, there's a relatively standard performance. If you look at baseline 2, you see that there's a relatively high measurement, and perhaps that's a learning effect. A person who, is aware that they have an intervention happening and they're maybe behaving slightly differently, but over time, presumably people return to their normal, their normal behavior. And so if you see something like this, you can analyze it. Traditionally, for single study design, statistical methods are not overly rigorous, but you're looking at a visual analysis and you're saying, at the baseline phases, after a return to baseline 2, it looks like a person's operating at 10 to 20%, whereas with the intervention, they're operating at 70 to 85%. So there's some strong data here showing that this intervention is actually having some sort of impact on a person's life. So, through some of those early phases, and these single subject research designs have been in the literature for at least 40 or 50 years. So they're around, they're just not generally viewed or even covered in research methods lectures. So phase 2, now you think you have a good project, you've run some single subject research designs, some different approaches. Now you're looking to refine your intervention. You're probably doing this, as we'll see through some of the later slides. You're often, in a technology perspective, continuously refining. So you're not just holding your intervention stable, you're actually continuously updating based on user feedback. And in many ways, why wouldn't you be? If you're conducting an RCT and you see early on that the results are not good, you end up canceling the study, right? Why not refine the study? And so there are more modern designs that we'll talk about, like stepwise designs, where we actually have the ability to iterate. And this is a reflection of how RCTs even are sort of adapting some of these single subject research design methodological approaches. So, phase 2, we're really looking at just better understanding users and making a better product and we're shifting a little bit away from evaluating the technology now, and we're switching now more to the evaluation of the intervention itself. So just really here, various modifications on different single subject research designs, the randomized controlled N of 1 trials. Here you have randomization introduced. So, we talked about randomized RCTs briefly, where you're randomized to a control versus an intervention group. Here I talked about a standard SSRD being an AB design. So baseline, intervention. You can randomize that, for example, so make it a baseline, then a baseline, then an intervention, baseline, intervention, any combination of these, and you will decide is, and you'll decide your randomization scheme based on what your feedback is from your users. So if your users are saying, oh, it was so obvious when I stopped using the intervention, and that's why there was a learning portion. I hope you guys can see me because I just got a notification that my internet was briefly disconnected. Can anybody hear me? Can I get a quick confirmation that I can still?
I can hear and see.
Yeah,
Excellent.
me too.
Okay.
All good.
Excellent. So, alternating interventions, so rapid alternation, I had mentioned in a single subject research design that, one of the things that we do multiple measures within each phase. Sometimes, for example, that can introduce some different forms of bias in both the user and in the researcher. So maybe instead of 5 or 10 measures within each phase, only go for one measure and rapidly switching between intervention and non-intervention. It's far fewer within phase measures. So here you see 2 different interventions, or back and cool, I guess on the bottom is no intervention, and the top one is some intervention, or vice versa. Ideally, you'll be able to see some sort of difference between between the intervention and non-intervention portion. Again, though, the caveat here is that the participants are serving as their own control. And so you would be doing multiple trials at the same time with different people, but collecting individual data and synthesizing at the end of the trial. Multiple baseline, non-concurrent, and concurrent designs are again just the idea that you can, so a concurrent design would be running the same intervention strategy on the same individual at the same time. A non-concurrent recognizes that in some cases, you just don't have the population available. And so, if you're working on some sort of condition that is relatively rare, you can only conduct an RCT for the most part if you're doing it all at the same time. If you stretch out your time window too far, then methodologically your RCT becomes weaker. But you may not have a choice. So do you just throw away a technological intervention that could be good because you can't do it at the same time? Or can we think differently about how we collect data? Also, group-based designs like RCT-ish designs are not, it's not that you can't do them with technology, it's just that you may not be able to do them. So interrupted time series design, you're basically just looking at, a person over a longer period of time. So now recognizing that these interventions sometimes, just doing a 1-week intervention is not enough. Maybe you're going to follow a person for years over time, and you're going to, collect a lot of data on that person initially, and then introduce the intervention, continue collecting data, and then remove the intervention and follow up. So it's basically a single subject research design over a long period of time. If you do this over different people, it increases the robustness, but again, the cost and time requirements and resource requirements go up. Just quickly taking a look at the time. So we're at 12:51. I'm going to go a little bit quicker, but trust me, we're almost at the end. One group pre and post test. So here, before you introduce an introduction, you see in the cartoon on the bottom right, you issue some sort of pre-test survey. Often is what we would do. We would do either like a validated clinical test or some sort of questionnaire to understand what a person is like at baseline, rather than just external measurements, but actually hearing their words and their understanding of what their baseline is like. Introducing some sort of intervention and then doing the exact same test or some modified version of that test post-intervention. So you get a difference between pre and post, where you're actually measuring your own external variables as well as soliciting information from a participant directly. Non-equivalent pre-test and post-test is the same thing, just that sometimes you might not have access to all the groups that you would want. So you're basically allowing people who do and don't have the issue to participate in the study. An example of that would be, for example, if you had voluntary participation in you think about an educational concept where I'm teaching a class and I have a voluntary tutorial. So people don't have to come. I can do a pre-examination of people's knowledge just before a lecture, after a lecture, and then after the tutorial, and then maybe after an exam. And I could compare the 2 groups, but they're non-equivalent because I'm allowing people to naturally select versus randomization. So some of the strengths of randomization are that you are trying to remove some of the bias, but some of the advantages of not randomizing is that you're actually allowing people in real world contexts to be able to share their opinions. And then of course, stepped wedge trial designs, which are RCTs, where instead of doing it all at once, you're intentionally ahead of time determining how you're going to stagger your intervention amongst different groups. In many cases, there are variants of stepped wedge designs where if you find your intervention is not working as well as you can change it. And in this way, you can see what happens when you change it on the impact of your pre and post groups. So I'm going to go a lot faster here because I'd like to give some time for Austin and anybody else to say something. This is again just more. Phase 3, we're now looking at things that are more and more about how well the intervention is working. But the big difference in phase 3 here from a technology developer is we're putting less emphasis now on the impact of the intervention and much more emphasis on the experiences of the users themselves. So tracker trials are a relatively broad encompassing term where we're acknowledging that something in the environment is changing, whether it's the technology and the intervention itself, whether it's the people, or whether it's the challenge. So COVID is a prime example. You'll see a lot of variants of tracker trials out there for COVID research where they're perceived as systematic reviews or reviews, but really it's about aggregating information and comparing apples to orange on purpose, understanding that the world has changed, the intervention has changed, the demographics of the people have changed. And so, the statistical rigor disappears in favor of some of the less statistically rigorous approaches that we've already talked about, but recognizing that we don't have to always control everything. So the benefits are that we don't have to wait for interventions to be fully developed, and we're actually allowing for these changes to be taking place. And then I think the last big one that I'll talk about are pragmatic trials. So really, these explanatory trials that most RCTs are out there for is trying to look at the impact of the intervention specifically on a very, very small number of outcome measures. Pragmatic trials are the exact opposite of that. I shouldn't say the exact opposite, but are very different from that in the sense that they're really looking at effectiveness. So what are the usual conditions that these devices are being used, or these innovations, or these interventions, as opposed to looking at whether the intervention is working under optimal conditions. So again, these pragmatic trials tend to be more of an encompassing term, but there are true pragmatic trial designs. Trying to stay away from being a research methods webinar. I'm not going to go into too much detail, but understand that in practice, most trials do have a pragmatic and an explanatory aspect. But for me, the big take-home message is that the explanatory aspects are the ones that are given all the credit and the credibility for success, whereas the pragmatic outcomes tend to be secondary outcome measures within these trials. So really, really quickly, what's the difference? Explanatory being the more exploratory or experimental in design, have strict eligibility criteria, versus pragmatic, which include anybody. Experimental interventions, everything is very controlled. I guess the take-home message is the intervention, what the practitioner does, both with the experiment and with the comparison, are very, very strict and very, very highly controlled, whereas in a pragmatic trial, it's the opposite. You're allowing people to do what they want. You're giving an intervention to somebody, for example, and if they never use it, they never use it. That's a valid result. That's something that we're interested in. And it would be more interesting to know why they didn't use it than to force them to use it and report on why they didn't like it, for example. So, with an explanatory, everything is rigid. Everything is defined a priori. Everything is strict. The outcomes are very, very specific. Compliance is very strict, and the outcomes are analyzed specifically for the primary outcomes. Pragmatic trials, in comparison, tend to be a lot more loose. No specific follow-up. You're solicited to participate. If you don't participate, that's in some ways taken as feedback directly as well. So it's kind of interesting to see that. So in summary, my take-home message would be that if you're thinking about technological interventions, consider what you consider high-quality evidence, and maybe think a little bit more broadly outside of things like randomized controlled trials. And with that, I think I'll stop talking. Thank you very much for joining.
Thanks,
And I'm
Steve.
sorry for going over.
No worries at all. We started a couple minutes late too, so it's not your fault.
Yeah, it's all us, Steve. Listen, I want to jump in really quickly because I know Aston wants to share his idea and I want to hear it too. Steve, I just want to say briefly, really enjoyed that. Really cool to hear about these different designs. And it's just a comment, not even a question. I'm struck by how a lot of what you've talked about today, these different designs, you're working with technology, you've got this good idea, you want to try something out, how a lot of that work is at odds almost, or a little different from our traditional, academic processes for research, how we do research. And it struck me, relevant to this audience, that the patient engagement work that is rapidly becoming popular in the last few years, patient-oriented research, is also disruptive. It also is a challenge to the paradigm. So some really nice sort of compliments there for me as I was listening to you talk. And you're absolutely right about, when you talked about that phased approach and the iterative nature, right? So getting data, using it while you get it, feeding it back in to change things, that jives so well with patient engagement and patient. Yeah, I was just struck by the parallels. That's all. So I appreciate that. Yeah.
And also, just a quick comment on that. You had said that sort of the dominant research paradigm is to be much more structured and well thought out, but I would argue that that only exists in healthcare and medicine.
Yeah.
So, within the Faculty of Engineering, for example, and within the Faculty of Business, you'll find that that's not the case. And so it's when you see a translation to medicine that it becomes an issue, right?
Yeah, that's a good point, because you're right. Even some of those last things you talked about, like for example, the non-parallel control group, you see that a lot in quasi experiments, right? In the education field, it's a well-accepted research way to do research out in the real world, which one could argue is pretty darn important, right?
Yeah, and then you see how Apple, for example, releases their new operating system. They're not doing RCTs, they're doing focus groups and interviews and business and market analysis. They're not doing, anything to do with RCTs. It's only within medicine, right?
Yeah, no, that was great. I really enjoyed that. Thanks, Steve. That was awesome.
Thank you.
Austin, did you have something you wanted to share?
Oh, I think you're muted, Austin. And maybe before you share, can you give a little context to where you're coming from? And I think you're still muted though, Austin.
You're still muted.
I'm telling you, mute. Yeah, Austin, you're still on mute, but I'm telling you, that is going to be the tagline of the last 2 years, isn't it? You're on mute, right? Or you're still muted.
I think in your case, on the bottom of your screen, Austin, there should be a.
I got it.
Oh, there you go. Yeah.
Okay, I got it. Sorry. I mean, I knew it was there. I just didn't know how to use it. But anyway, the idea of using technology is, well, anyway, I'll give you my background. Okay, first, I spent my whole career in telecommunications. I started in 1974 with Newfoundland Telephone. Anyway, to make a long story short, my participation, say, in the healthcare industry may have started back in 1984, 85, something like that, when I was what they would call at that time a central office installer. And MUN had what they call telehealth at the time. That was back in 84 or 85. Anyway, there was no internet at that time. It was all analog. And that was my participation, was putting a radio channel from MUN. It was a 64 kilohertz full channel, right? Radio quality equalized up to all the nursing stations in Northern Labrador. So myself and another technician from Newfoundland Telephone and a helicopter pilot from Newfoundland also flew up to Labrador, because that's where I worked. And we installed basically a microphone and a little station in all the nursing stations so they could communicate directly with the MUN. For all that, at that time, all the nursing stations were populated by nurses, believe it or not. But I don't think that's the case anymore. But anyway, after that, let's skip to 2015. That's when I had retired from Newfoundland Telephone. I started my own company in 2005. But anyway, recently, I entered the healthcare system in 2015. And I've always been interested in technology. And I've been part of several research groups across Canada. Most recently, because we touched on technology here, we've had a meeting with a group in Alberta, the University of Alberta, who are doing directly what you're talking about. They're doing, I'm not sure what kind of trial it is. I don't know if it's RCT, pragmatic, or whatever. I'm no expert on trials, but I do know how to do research. But in a different manner. But what they're using there is a software and devices that will measure, take for an example, a pediatric patient who undergoes a heart transplant and they're recovering. So they're gearing towards the recovery of young transplant patients, right? So what they decided to do was they done a trial. They picked their patients at the trial, and it was under the care of their physician, their cardiac physician, and they were monitoring the rehab. This was a home application, actually, right? So they would have the software that would monitor all the vital signs of the patient: oxygen level, heart rate, arrhythmia, you name it. They were monitoring it, and they had created a game so that the participants could watch the game like they would regularly do at that age when you're between 12 or maybe 10 and 15 years old, right? They would play the game that was created by the team that were doing the research to motivate the patients to use exercise as part of their rehabilitation. At the same time, each patient would be individually monitored, because you don't want to, get to a point where you're stressing the patient out. Like take, for instance, the Peloton, where people have overexerted themselves on the Peloton and had to call 911. So using this device, like you're saying, to validate the effectiveness or the efficiency of using exercise to help these patients in particular, was just a start. Because under my personal experience in exercise and rehabilitation it's a no-brainer to me, because that's what I do every day. And ever since I was in the healthcare system, I was forced into looking after myself. And exercise played a key role in what I was doing. But the intriguing part of what you're talking about, using technology in the home, we already know most homes had the technology sitting around them all the time. Now, remote places in Labrador and Newfoundland, the biggest problem we've got here is the broadband access to those communities.
Yeah, and your comment is really your comment and the explanation of that type of intervention is a perfect example for sort of the heart of this webinar, because if you think about a traditional clinical evaluation of that type of exercise therapy intervention, the conclusion of an RCT may indicate that that form of exercise intervention made no measurable health impact. However, a clinician might say that's not the outcome that mattered. What happened is this therapy actually got kids interested or got adults interested, and they were doing exercise every day. And while the clinical outcome of loss of mobility didn't improve, their overall health and happiness and wellness improved, right? And so a non-standard, a non-traditional research method might actually elucidate that the people were really happy with it and excited. And a therapist might actually say, hey, I managed to actually get them to do some stuff, even though, yeah, they're still injured. It was a net benefit improvement in overall outcome, right? So that's a perfect example of how a non-traditional study design could
Absolutely. And when sorry to interrupt, but when they done the first two trials, the participation rate was 80%. They had no dropouts. They had very few, what I'm saying, but
see, and that may open the door for another trial, which actually has better, that other trial that might have better clinical outcomes can now learn from this approach and say, hey, let's bury our intervention in that technological intervention, right? But without having an RCT behind it, that work would never be published even, and nobody would even know about it, right?
Absolutely.
Yeah, wonderful point.
That was why I wanted to bring it up, was that this was the first time that I've ever seen somebody in the medical field take the lead in promoting this type of, like I told the pediatrician when I was on the call, when I go to my GP, somebody should write a prescription for me for exercise. Now they have a specific tool they're using a bike, right? But you can adapt this technology to any elliptical, weight machine, you name it, because of the technology that's available today. And I'm talking about technology inside of the home, low speed or, variable speed connections to IoT devices. That will revolutionize the home care aspect as far as I'm concerned.
Absolutely.
But one of the other things that is a pet peeve of mine, I'm sorry, I'm dominating the conversation, but
Not at all.
listen, I don't usually get a chance to talk. But anyway, one of the key things, like I've been doing my research on myself for the past, since I got into the health industry, healthcare predicament I'm in. But the one drawback here is access to information for me anyway. I cannot get it, right? It's unfortunate because almost every other place, I think it would help the patients, especially patients like me and patients who are, can understand or educated enough to understand what their own medical data is. But the unfortunate part of the whole system is that we're restricted by the rules that are in place for, for everybody, me and everybody else included there.
Yeah.
But anyway, I'm doing my best to change that.
Yeah, and I really
I can.
appreciate your feedback, Austin. You give me hope that this is a worthwhile thing to talk about as well, because even within multiple sclerosis research, one of the big things that is researched is general mobility on an EDSS scale. So how well you can just move around, but many people with MS, for example, are very worried about falls.
Absolutely.
So if you want to contribute to the literature in a high impact way, you're forced to do an RCT related to something that a lot of people don't even necessarily, not that they don't care about, but maybe not the hottest topic that's burning in people's minds. So that's excellent. It's really, really good feedback, and I'm glad that it seems like we had some good commonality and connection in this. So thank you for sharing.
Yeah, no problem. I could share a lot more, but we don't have enough time.
Fair enough.
Thanks so much, Austin. We always appreciate your commentary and your feedback. So I know we're
appreciate that. Thank you.
Thanks, Austin. We're 10 minutes over time, so I think that'll probably conclude today's session. So thank you so much, Stephen, for a very interesting and different session compared to the others that we've had. I learned a lot, I will say. So thanks for taking the time out of your busy schedule to join us for this research design series. So this will close out kind of our quantitative research design series. We do have our qualitative design series starting, I think we're skipping a week and then we're starting the next week after, and Holly will be the first one presenting an overview of qualitative research, and then we have a couple of other sessions, including a session on interpretive description as well as some others. So stay tuned for those. You can register for them on the NL support website. So I think if we've kind of reached all of our comments and our questions, we'll close out today's session.
Thanks, Steve. Thanks again. Really enjoyed that. It's awesome.
Thank you.
Thanks.
Thank you all very much. Thank you.
Thank you so much,
Thanks, guys.
Stephen. Take
Bye,
care.
guys.
Bye-bye, everyone.
Bye.
Thank you again.